So you asked me to talk on hemodynamic aspects, which forms the mainstay of congenital heart disease. I'm a pediatric cardiologist, but we work in a unit which is joined with the adult congenital heart disease unit. So I'm going to use a case to illustrate some of the key features of congenital heart disease as regards the hemodynamic aspects. It is a rather puzzling case in some ways, and I find it very interesting. So she was born in 1982 in a different era and was deemed too complicated to repair at that time. She has a complete atrioventricular septal defect, formerly called an AV canal defect, with the added complications of a small left ventricle and a double outlet from the right ventricle. I'll go through the diagnosis again in a moment. She was breathless when she was young and was thought to have developed Eisenmenger's. In adult life, she presents again with increasing effort intolerance and a stable but reduced saturation of around 89%. So for the sake of those who may not be familiar, most of you know what an atrioventricular septal defect is, and here we have a sketch of it. Oh, sorry. Doesn't matter, I think we'll skip that. That's okay. So looking at the picture over there, you will see the sketch of an atrioventricular septal defect, which is different from having a simple ASD and a VSD. As you will see in the middle picture over here, where you have the pathological specimen, there is an atrial septal defect which spans the lower part of the atrial septum up to the upper part of the ventricular septum. There is some asymmetry even in this case, but here it happens to be a small right ventricle. It is the atrioventricular valve that is special in these defects, and when unbalanced, the valve can be committed more to one side than the other. The valve is not as simple as the mitral and tricuspid valve, but a composite common valve made up of 5 leaflets, which has to be partitioned into 2. So that's an atrioventricular septal defect. What is meant by a double outlet right ventricle is the 2 vessels arise entirely or predominantly from the right ventricle. There can be various forms of it. This patient also has a small left ventricle. By that, we would want to define whether it's just narrow or whether it falls short of the apex. And we will look at all this. So in considering the hemodynamics, we start off with the anatomy, which has a bearing on how the blood flows and so on. There are a number of questions which we are looking at, and I have a few selected clips. First of all, we want to see the size of the ventricular septal defect. If the ventricular septal defect is large, then by implication the pressures on either side must be equal. We would want to know, if we're going to consider any repair at this stage, which is what the question is about, is the left ventricle of an adequate size to maintain the systemic circulation after repair? This is in the context of it being said to be small. We want to know whether the left ventricular contractility is good. We look at particularly the free wall motion, because we know once the septum is patched, the septal function may not be entirely reliable. But most of all, we want to know whether the atrioventricular valve, which is a common valve, can be committed to both ventricles, and in particular, the left ventricle. So in this picture, we carefully look at how the valve opens and what its potential is for committing it to the left ventricle. We go on to the short axis view with the same thing in mind. By serial short axis cuts, we'll want to know whether the left ventricle extends to the apex. Clearly the right ventricle is large. That is not the question. It's the size of the left ventricle and its function that is important. A 4-chamber view shown in the traditional adult cardiology format with the apex to the top, clearly demonstrating a common atrioventricular valve and showing its predominant preference for opening into the right ventricle. You will see some subvalve apparatus going into the left ventricle and some opening into that, and a single view isn't enough, but it does seem as though the valve prefers the right ventricle. You would also want to look carefully at the left ventricular size. It falls just short of the apex, which is of relevance in thinking whether anything can be done. Clearly, it was deemed inoperable, but in a different era. Color Doppler now to look at the hemodynamics. We notice that the blood flow from the pulmonary veins is quite prominent. suggestive of a good amount of pulmonary blood flow, but not necessarily so. We noticed that there is a bit of atrioventricular valve leak. And again, in considering a surgical repair, we would want to know how difficult the valve is going to be, and if it's already going to be leaking and is asymmetrically aligned, that would make the repair, that would make a repair with a competent non-stenotic valve quite difficult. It's a double outlet. In considering the hemodynamics after surgery, we would want to know where the aorta is in relation to the ventricular septal defect. This is a modified long axis view, and the anterior vessel in this case is the aorta. The anterior vessel is the pulmonary artery. The aorta is the posterior vessel, and therefore is closer to the ventricular septal defect. So here is a defect where if it was born in the modern era, we might consider a repair, although it would be a high-risk one. Now we move on to the information about pressures, and because a key question here is, what is the nature of the pulmonary circulation, pulmonary arterial tree? So you've already had other talks alluding to this. The pulmonary artery pressure is derived by the equation 4 times velocity squared as it applies to the tricuspid regurgitation jet. In this case, it's 4.6 meters per second, and at the right atrial pressure, and is approximately 90. But actually, given that this is a large atrioventricular septal defect, the ventricular pressures are more or less equal, and the pulmonary artery systolic pressure, in the absence of pulmonary stenosis, is going to be at systemic or near systemic levels. So it is the diastolic pressure that is not predictable looking at the anatomy, so we do need the Doppler for that. As you see in the diastolic Doppler trace, the initial part of the Doppler is high, but when it comes down to the end of diastole, it's slightly lower, and that is what corresponds to what we would normally get at cardiac catheterization, which is a little picture shown on the side there. The pressure continues to fall in diastole, and when we talk about diastolic pressure, it's the end diastolic pressure. So again, applying the usual formula of 4 times velocity squared, and this time adding the right ventricular end diastolic pressure, we get an estimated pulmonary artery pressure of 30 millimeters mercury. So this person does have severe pulmonary hypertension. So we now need to move on to cardiac catheterization to get more robust data, perhaps, on these pressures. And these are the pressures and measurements we get. Clearly, she has severe pulmonary hypertension. Pulmonary artery pressures are 94 on 32, which do correspond to what we got on echocardiography. But does this mean she has severe pulmonary vascular disease? Of course, she must have a degree of pulmonary vascular disease. How do we know that she has severe pulmonary vascular disease? For this, we need to see in what context these pressures are. So we need to measure the shunt, or rather the volume of blood that goes into the lungs to have some meaningful assessment of what these pressures mean. And this is the Fick principle, as you are familiar with, is used in this. That is to say, the amount of oxygen taken up in the lungs is the same as the amount of oxygen released in the body. So the uptake in the lungs will be equal to the amount of blood, that's QP, that goes through it, and the amount of oxygen that is put in there from the pulmonary artery to the pulmonary vein. Similarly, the one released in the body will be equal to the amount of blood versus the difference in saturation between the aorta and the mixed venous saturations. And because QP and QS, the flow that is, are difficult to calculate, it is customary to have a ratio, which is very easy and simply derived by the equation given down there. So at cardiac catheter, when she had a cardiac catheter in adult life, one was somewhat surprised to find that she did have a large volume blood flow to the lungs. Her vena cava saturations rise from the low 60s to a pulmonary artery saturation of 90. And this would indicate that there must be a large volume pulmonary blood flow even now. So that's the shunt that we measured now. So she's got a lot of pulmonary blood flow. She's got severe pulmonary hypertension. We would go to the next step of knowing what the response to oxygen is. We're trying to do that because oxygen is a pulmonary vasodilator. We want to see what happens to the shunt. And these are the measurements we get when we expose her to 100% oxygen, and the shunt is still very high. Of course, at those levels, it is an approximate measurement of the shunt, and I've got it close to a single figure of 8 to 1. So she has severe pulmonary hypertension in the context of a large shunt, and we want to have a measure of what the vascular resistance is. And there are kind of numerical figures that we can use. But before that, on the matter of shunt calculation, we have to be careful because we take these measures and draw conclusions from them which are of great relevance in the management. And we have to be sure that the sample is not contaminated, and that is fairly easy, and that the saturations are done in rapid succession, often on the way in as well as the way out, so that you get two samples to look at. Of all these saturations in the presence of large shunts, it is the saturations that go into the denominator that matter most in terms of their influence. And if you look at the figures down there, it is the pulmonary artery saturation. If there is an inaccuracy in any of the other saturations, it doesn't alter the final figure so much. But because the denominator is always small in comparison to the numerator, even a saturation measurement out by 1 or 2 percentages will have an enormous influence on the QPQS. So it would be best to do the pulmonary artery saturation not only in the main pulmonary artery but also the branches, so that you have good evidence of what it is that it is. So having derived the shunt, we move on to pulmonary vascular resistance. So the concept of resistance is one of what is opposing the blood flow, which is manifested by the pressure which has to be considered in relation to the volume of blood going in. And in this case, it's the arteriolar resistance, that is the pressure, the resistance provided by the pulmonary arterial tree, for which you have to take away the left atrial pressure from the mean pulmonary artery pressure. And it's done in Wood's units. It works out to about 3 Wood's units in air, going down to 1.6 in oxygen, and the corresponding QPQS is given there. So she does have pulmonary vascular disease. There is no doubt about that. It's a question of how severe it is what we are trying to assess at this rather late stage of somebody who has so far been deemed inoperable and may well still be. So to look at all this, because it is such an important thing, we would routinely do cardiac catheterization. We would routinely do cardiac MRI. And this is done to verify the inferences we have made about the anatomy, in particular in this case to look at the valve commitment, which still looks like it goes to the right side, our appreciation of the left ventricle, which still looks as though it falls just short of the apex, but almost to it. And MR is also very useful to recheck the QPQS, which works out in this case to again 5 to 1. So our data is accurate. Now, of course, we are still left with a very difficult decision in this 33-year-old who has a lifelong history of effort intolerance and now complains of even more, who has had systemic pulmonary artery pressures, but in the setting of large volume pulmonary blood flow, she does have pulmonary vascular disease, but not very severe. But really, as regards consideration for surgery, it is how complex the operation is going to be. That is also what is important here. If an operation was to be carried out, it will be done in 2 stages. First, you'd want to band the pulmonary arteries to see whether the pressures drop. And in some cases, you might just band and leave alone. But the band is not without problems. It will cause arterial desaturation, and the valve may leak further. This valve is already leaking. In the setting of an atrioventricular septal defect, a pulmonary artery band is not always tolerated well, particularly if the valve is leaking. But the banding alone is not really a kind of destination, end destination. So if you do a band, it's with the intention of a full repair. And that is where we would feel that this case is not really suitable for. This left ventricle, the adequacy of it is very uncertain, and it would be a very high-risk procedure. So what I've done here is to illustrate a difficult case that we have currently in the department, where we grapple with what is best to do. She had been labeled as an Eisenmenger for a long time, and to an extent that was not an unreasonable thought. What we had not foreseen was that she still had a very large shunt, but she's now 33 and has a degree of pulmonary vascular disease. And if it had been in a much more simpler defect, like a simple VSD, we could have considered pulmonary artery banding and a repair. But in the setting of an unbalanced AVSD with a double outlet, that would not be an advisable course. And that is our current view. And these things are very debatable and arrived at by a joint decision of our team of pediatric cardiologists, adult congenital cardiologists, cardiac surgeons, and cardiac radiologists. I want to move on briefly to another case, just very briefly to keep to time. And this is one of an operated heart disease, just to illustrate the hemodynamic principles again. So this is somebody, one of our patients, who is 27 years old with tricuspid atresia, initially with unrestricted pulmonary blood flow. So if you get tricuspid atresia without pulmonary stenosis, you would have a large volume of blood going to the lungs. So he has an initial pulmonary artery band. Unfortunately, the band migrated. That is to say, the band was pushed along the main pulmonary artery, and it resulted in occlusion of the right pulmonary artery. Here is a cardiac catheter done at that time, and just to go through the same principles of shunt calculation, to illustrate the fact that in cyanotic heart disease, even though they may be cyanosed, it doesn't necessarily mean that they have low pulmonary blood flow. In this situation of common mixing, as you look at those figures there, the aortic to the mixed venous saturation, pulmonary vein to the pulmonary artery saturation, the QPQS is about 1:1. So he has had the pulmonary artery banding as an initial procedure to keep the pulmonary artery pressures low. The next stage of repair in a single ventricle palliation, I'm sorry, let me just go on to looking at those pressures again. As we said, the pressures are affected by this band migrating distally, and this is a diagrammatic illustration of what has happened. With the band migrating distally, it has distorted the bifurcation anatomy and has diverted the blood flow more to the left pulmonary artery than the right. And when you do the cardiac catheter, we found a pressure of 20 mean in the left pulmonary artery and a mean of 10 in the right pulmonary artery. So this sketch is to illustrate the concept of a transpulmonary gradient, which is important in single ventricle repairs. What we are assessing here is what is the pressure difference between the pulmonary arteries and the left atrium. Of course, this may sound like a very low pulmonary artery pressure, and it is very low in the context of the normal population. But when you are considering a single ventricle repair, bypassing the heart and the venous return directly returning to the pulmonary arteries, which is what it's about, a pressure of 20 and a transpulmonary gradient of 15 would be high. But then you have to look at what is happening here. The pressure on the right side is only 10, and what that means is that most of the blood that goes into the pulmonary artery is going to the left side and less to the right, and therefore a transpulmonary gradient of 15 in this case is happening with a large volume of flow. So it is still suitable to consider a KO pulmonary connection, which I illustrate over here. So this is the next step we wanted to achieve, where the superior vena cava blood is directed into the pulmonary arteries. And as you see there, the caval blood now, as it comes into the pulmonary arteries, doesn't have a ventricular pump. And that is why the resistance offered by the pulmonary circuit is very important for it to flow passively. And that is why there was a concern about the transpulmonary gradient of 15. The inferior caval blood goes through the heart and mixes with the other side, that is the pulmonary venous blood. The third stage of repair in the single ventricles consists of performing a total cavo-pulmonary connection. In that era, we were doing what was called a lateral tunnel, where the lateral side of the right atrium was partitioned off, and the lower part of the SVC reconnected as shown in the diagram there. So now the inferior and the superior caval return go directly into the pulmonary arteries, and then through the pulmonary arterial tree and capillaries and on to the left side of the heart. It is also customary to leave a small hole or a fenestration in the lateral tunnel, and we will look at how that works. Now, I'm showing these pictures here to show another complication that the single ventricle patients have. And if you look carefully at these two injections on the right and the left side, the injection in the right side shows a mottled, hazy appearance as soon as the contrast goes in, followed by immediate flow of blood into the pulmonary veins. Whereas the one on the left side shows a fairly normal-looking pulmonary arterial tree, and it takes a while before the blood gets back into the pulmonary veins. Unfortunately, he has the complication of a pulmonary arteriovenous malformations, which is an acquired thing in the right lung, which happens in people after a cavo-pulmonary connection. So going back down to the fenestration injection again, this is an injection in the inferior part of the venous circuit in the lateral tunnel. And as you see there, the lateral tunnel fills, and on its vertical course, you see the fenestration jetting blood out into the common atrial chamber. So the purpose of this is to relieve the pressure or act as a relief valve, because what is happening is that the vena cava blood has to traverse the pulmonary arterial tree without the assist of a ventricular pump. So it's just going on venous pressures. And for any reason, if the pulmonary arterial resistance were to go up, that will block the circulation. And the fenestration acts as a let-off valve, if you like, to allow offloading of some of the venous return back onto the other side. The price you pay, of course, is desaturation. And the organ that we are trying to protect in all this are those of the inferior caval drainage, mainly the abdominal organs like the liver, and in particular the intestines. Because the intestines have to go through the portal venous system, back into the liver, and then through the hepatic veins onto the inferior vena cava. And in these single ventricles, as time goes on, the liver can get very nodular and fibrotic, and there is a gradient that builds up from the inferior vena cava to the intestinal drainage, which makes them very vulnerable to complications. And unfortunately, this patient does have that complication. From the age of about 19 years, he started losing protein through his gut. At that stage, the fenestration was ballooned open. And as you see there, we would want to reduce the pressure in the caval return. And a repeat cardiac catheter, he has a reasonable pressure of 20 in the inferior vena cava compared to a pressure of 13 in the atrium, which probably reflects the high-end diastolic pressure, but his protein-losing enteropathy continues. So I think I've used this case of a single ventricle to illustrate the type of repair that is carried out, but also to tell you one or two sort of basic principles of a single ventricle circuit in terms of the hemodynamics. The arterial desaturation in a person with a single ventricle can really happen in the presence of normal, reduced or excessive pulmonary blood flow. And when we talk about pulmonary artery pressures in a single ventricle circuit, they are completely different from the concept of pulmonary hypertension that we talk about in the normal circuit. I hope I have given you a taster or some sort of understanding of hemodynamics in the single ventricle as well as the unoperated congenital heart that you might encounter in adult life. Thank you.